Welcome to this morning's left main intervention. My name is Tan Hui Chim, and I'm co-chairing with Professor Huon. Hopefully, will come soon enough, and that we have our fellow panelists here, Dr. Donny Holman, Dr. Nguyen Van Tao, Professor Myon, and Nguyen Van Tan as well. So, without further ado, I'd like to invite our first speaker,
Yeah, thank you.
Dr. Ang Jo Ming from Korea, to tell us how to decide and optimize in bifurcation stenting.
Thank you. Thank you, Chairman. Could you run? Could you, thank you. My topic is how to decide and optimize left main stenting. So what is the decision for left main bifurcation treatment? So first, do we have to consider the bypass surgery or PCI? But based on the previous randomized trial and the meta-analysis, we uh, uh, showed that there is no mortality difference between PCI and bypass surgery up to 5 years. Longest follow-up was up to 10-year follow-up. So then we decided to do the PCI. Then what is the next issue? We have particularly left main bifurcation. We needed to decide the provisional stenting or two-stent technique. So actually, we don't know how to decide the provisional or two-stent technique. We have a two randomized trial. The trial result is opposite. And another, the issue is how to optimize the provisional stenting and two-stent technique. The first of all, I like to start with how to optimize the left main stenting. The previously, our hospital, Dr. Kang, Professor Kang, presented a very famous numbers 5, 6, 7, 8. Is 5 for circumflex ostium, 6 for LAD ostium, POC 7, and this left main 8. But this criteria is very popular. But this criteria came from came from the very heterogeneous population, including the simple crossover and two-stem bifurcation stenting. In addition, this criteria is again made against the 9 months instant restenosis and validated against the 2-year follow-up. So in addition, another criteria was Excel criteria. Number is a little bit bigger than our 5, 6, 7, 8. Another, the Spain registry criteria more complex, but I think we didn't use this criteria. So the first we did some how to optimize left main stenting based from the two-stent population only. We separate the two-stent and one-stent population. So we only enrolled in this study. We only patient underwent the two-stent technique by Crochet technique. Crochet technique is including the conventional crochet and balloon crochet, etc., etc. So the we measured the 3 point, the distal leg main, LAD ostium, and circumflex ostium. So we evaluated the relationship between the minimal stent area and clinical outcomes. So clinical outcome was major adverse clinical outcomes. That's MI repeat intervention. So distal leg main that is not associated with the clinical outcomes, but the LAD ostium cutoff value was 8.3, nicely very significantly associated with the patient clinical outcomes after the two-stent crush technique. So if minimal stent area of LAD ostium larger than 0.83, 5-year event rate is only 5.3, but smaller than 8.3, 17.4. In addition, circumflex is very important for left main two-stent technique. Circumflex minimal stent area is very significantly associated with the clinical outcomes. Look at the spline curve, the linearly associated with the clinical outcomes. Smaller circumflex ostium minimal stent area, higher event, and larger circumflex ostium, low event. So when there was under expansion, particularly in the two LAD and circumflex under expansion, very high event rate, but the no under expansion, very low event rate. So the we were shown that bifurcation two-stent technique 8, 11, 6, 8, 11 is associated with the better clinical outcomes in case of two-stent technique. How about the provisional stenting technique? We also evaluated the 3 point LAD ostium, distal leg main, proximal leg main. So proximal left main area 11, and distal left main is around 8, and LAD ostium, the 8, was nicely associated, significantly associated with the patient outcomes. So similarly, two segment under expansion show that the very significantly higher event rate, but no under expansion, only one segment under expansion show that the lower event rate compared with the under two state under expansion. So we know that how to optimize the state optimization for one provisional stenting and two stent technique. So I have to say I want to say that the most important thing is the minimal stent cross sectional area. We input the every variables, for example, relative expansion, plaque burden, etc., but only one independent predictors after stenting is a minimal stent area. So I like to move to the how to decide the one stent crossover or two stent technique. So we have two randomized trial, DK Crush 5 trial and EBC main trial. Two randomized trial enrolled actually same patient to unprotected left main disease, but results are different. DK Crush 5 trial favored the two-cent technique, upfront two-cent technique, but EBC main trial favored the simple provisional simple crossover technique. Why? I think in the DK Crush 5 trial, two-cent in the provisional group, finally two-stenting was done in 47%. But EBC main trial in provisional group, finally two-cent technique was done in only 22%. So angiographically, inclusion criteria is a true bifurcation, but actually these two trials may have a different complexity of left-to-right bifurcation. In addition, these two trials was done by the different operators. That is why the different outcomes. So I think that these two studies will give us this kind of the saying the selected left-hand bifurcation strategy wisely. The simple left-mind bifurcation we can cross over, but the complex bifurcation disease we need to send technique upfrontly. So there are lots of left-mind bifurcation. So somebody want to treat the all bifurcation by simple crossover stenting. Somebody want to treat all this left-hand bifurcation using the two-stent technique. How to decide the simple crossover two-stent technique? So currently we have only one the criteria to select a two-stent or a simple crossover definition criteria. But definition criteria is angiographic criteria. You know, angiogram is not reproducible. My visual estimation is different from the other visual estimation. This is a very important case, very example. The upper panel and lower panel circumflex ostium looks tight, but if you look at the IVUS intracoronary imaging, upper panel circumflex ostium is very tight, but the lower panel circumflex ostium looks fine. So upper panel we can treat it the upfront two stent technique. Lower panel we just do the simple crossover. So IVUS evaluation for circumflex ostium is very important to determine the two stent crossover or simple crossover stenting. So the from the registry perform the simple crossover stenting, we only enroll the patient to who have data. I was pulled back from the circumflex to left main ostium. So we try to predict the circumflex compromise after the left main to LAD crossover. So after simple crossover stenting, median uh, uh, in the patient circumflex ostium, the median minimal lumen area was 4.3, plaque burden was 55. In patient underwent simple crossover stenting, this is a distribution of plaque burden and minimal lumen area. Red dot was acute circumflex compromised cases. So the 24 cases, 17% of circumflex compromised after simple crossover stenting out of 141, so 17%. So what is the best predictor of circumflex osteal compromised? Minimal lumen area and plaque burden is two predictors. So circumflex osteal diameter stenosis angle and circumflex lesion length was not associated with the incidence of acute circumflex compromised. So cutoff value minimal lumen area was 3.8. Plaque burden is 57. So we grouped the uh, high risk group and low risk group. So high risk group, particularly minimal lumen area small, less than 3.8, plaque burden more than 57. One out of three cases suffered from the circumflex osteal compromise after simple crossover stenting. So we grouped the high risk group and low risk group. So we compared the upfront two stent technique. Upfront two stent technique, yeah, as we expected that smaller lumen and larger plaque burden. So but this is a Kaplan-Meier curve. Two stent technique, high risk circumflex ostium, and one stent technique, high risk circumflex ostium, similar event rate. Two stent technique, low risk circumflex ostium, one stent technique, low risk circumflex ostium, very low event rate, similar between. So actually, circumflex fate, patient fate already determined based on the how complex it is. Then what we should do. So we compare the two stent technique with the ones in high risk circumflex ostium. Blue line is a high risk circumflex ostium. The green is a two stent technique high risk circumflex ostium without under expansion, full under expanded stent. The red is with some under expansion. P-value is not significant, but if we do upfront two stent technique in case of high risk circumflex ostium and do something good, then we can reduce the some event. So this is my final slide. New imaging algorithm for left main bifurcation treatment. Look at the left circumflex ostium, high plaque burden, low small lumen area, no, definitely provisional stenting. High, yes. Consider the upfront to stent technique. And whatever you choose, whatever you do, final optimization according to this number is very important to guarantee the long-term outcomes. Apology for many numbers, just the benchmark, not absolute numbers. But this is really I want to say, please be active imaging guided left main PCI interventionist. Chasing a goal leads to a better result. Simply watching without action achieve nothing, I think. Thank you for your attention.
Thank you very much for keeping the time. Maybe you can just stay on the podium for just to ask you a couple of questions. Any comments from panelists?
Yes, Dr. An is very interesting topic regarding the side branch. You know, in the professional stenting, sometimes after stenting on the left ventricle LAG, we saw some narrowing on the curve, and then sometimes if you use IFOS, it's less than 6. But if you put FFR, most of the time look like okay.
Yeah.
So in this scenario, what should we do?
So okay, thank you very much. So we had a very small data. So the if before provisional stenting, after the crossover, the pinched side range we measured FFR, only 7% of pinched side range FFR is lower than 0.80. In addition, the if FFR is lower than 0.80, I don't like to do uh, more procedure for circumflexes. So if you do something, please measure the FFR. But the to do something, but usually after simple crossover stenting, I don't measure the FFR because usually the FFR is negative.
I have one question to
Yeah.
Dr. Han. Usually, you propose a very good number for the two-stent technique, 6, 8, and 11, and we confirm that the stent luminaries are quite large enough. But finally, at that time, we do not final part. We need the additional part, even though we achieve such kind of larger lumen area in the bifurcation two-stent technique.
So this is I think a very important question. So nowadays we have to consider the how to say part technique part. So parties came from the angiographic guided PCI. This term is from the angiographic guided PCI. So because the without part, the many left main stenting was non-opposed to the vessel wall, some etc. etc. So the without any information of vessel size, the some guideline recommended the use the bigger balloon and final part. But if we do the imaging guided PCI, the stent is already well opposed to the vessel wall according to the vessel size. So actually I don't need additional part if achieve the sufficient minimal stent area. So I think if we do the imaging guided PCI, we don't need to use the term part. So actually imaging guided optimization technique, IOT, is a better terms than part technique, I think.
Yeah, the last question. In some patients, they have the very diffuse calcified lesion in ostium of LAD and circumflex, and the patient refused to do the CABG. What do you think you will do with the high, with the non-covalent balloon with high pressure to achieve the your goal, your area as you told?
Yeah, this is a very important questions. Thank you. But yes, you know that the very calcified circumflex ostium, LAD osteal disease, prohibited the well span expansion. So the before stent implantation, high pressure balloon dilatation is very important. In addition, nowadays I didn't apply I didn't have enough experience for the IVL, but in the future, if we use the IVL, then we can achieve the better stand area than before.
Yeah, thank you very much.